evening, everyone. Welcome to our first inaugural Asia Pacific Glaucoma Society webinar.
Hi everyone, and welcome to this month's webinar by Asia Pacific Glaucoma Society titled Visual Field Preservation, How to Achieve Target IOP and Preserve Visual Fields in Glaucoma Patients. My name is Mukto Etsegmet. It's my great pleasure to be your moderator today. Before we get started, I would like to go over a couple of items. APGS welcomes everyone to become a member of the society. The Asia Pacific Glaucoma Society is open to glaucoma, ophthalmologists, researchers, trainees, specialists, associates, and corporations with the affiliation in glaucoma. There are many reasons to join APGS, and on the screen are just a few items which we can share with you. You can register as a member by scanning the QR code. All APGS members gain access to all recordings of the previous APGS joint symposiums, masterclasses, and webinars. One final disclaimer: presentations are intended for educational purposes and don't replace independent professional judgment. After this webinar, you will receive a short feedback survey that will let you be eligible to receive an e-copy of the 4th edition of the Asia Pacific Glaucoma Guidelines. We would really appreciate you taking a moment to complete it. Only after completion, you will receive a certificate of attendance. I'm sure that you will want to post questions to our speakers. There will be a question and answer session at the end of this webinar, and you may enter your question in the comment section. And finally, before we begin with the webinar proper, I would like to thank Beatrice for its support towards APGS activities, including today's webinar. It's with immense pleasure that I introduce Dr. Dilruani Ariasinga, who will share her presentation on how to set target IOP, or principles of initiating and adjusting medical therapy. Dr. Ariasinga is a consultant ophthalmologist at Golden Key Eye Hospital, Colombo. She graduated from Colombo University with 5 distinctions and 4 gold medals. She obtained her MD in ophthalmology in 2003 and was awarded Dr. Virashina Gold Medals for best performance. She was trained at Catherwell University Hospital, UK, and obtained FRCS in 2005 and did the glaucoma fellowship at Southend University Hospital, United Kingdom. She was the secretary and president of the College of Ophthalmologists of Sri Lanka, also served as Secretary of Glaucoma Interest Group of Sri Lanka. Currently, she is the chairperson of the Glaucoma Interest Group of Sri Lanka. She graduated from APO LDP in 2016. She is a council member of SARS and member of APO Women in Ophthalmology Working Committee. She has 23 publications in the Journal of Council and was awarded Best Paper 2 times. Presented posters at European Glaucoma Congress, World Glaucoma Congress, and APO. She was an invited speaker at the World Ophthalmology e-Congress, World Glaucoma Virtual Congress, APGS symposiums, and many local meetings. Dr. Arya Singh, the floor is yours.
Good evening. At the outset, I'd like to thank the APGS for giving this opportunity. Today, I'm going to discuss how to set target IOP or principles of initiating and adjusting medical therapy in glaucoma. I have no financial disclosures. I will start my presentation with a case history. This patient is a 70-year-old lady who presented to us 3 weeks ago. She had been on treatment for glaucoma since 2013. She was started with Latanoprost, and later in 2021, brinzolamide was added. She gave a very strong family history of glaucoma. On examination, other than the cortical lens opacities in her left eye, rest of the anterior segment was normal. At the time of presentation, intraocular pressure in her right eye was 17 and left eye was 19 mercury millimeters. Angles were open. Central corneal thickness was normal. Fundi showed significant inferior and superior notching in the optic disc in her right eye and superior notching in her left eye. In both her eyes, the nerve fiber layer defects have progressed over time. Her visual fields have also progressed over time, particularly her left eye. Here I have plotted the intraocular pressures against the OCT changes over time. In 2021, as there was a progressive loss of nerve fiber layer, the brinzolamide was added. But even after adding the second medication, the structural and functional loss had continued. So what should be the best IOP to halt the progression in this patient? So how can we judge or decide the best IOP for an individual patient when we are initiating treatment for glaucoma? So this is the concept of target IOP. This patient wouldn't have lost certain amount of vision if the IOPs were reduced to desired target at the correct time. As you know, lowering of intraocular pressure is currently the only therapeutic measure for glaucoma management. Many long-term randomized trials have shown the efficacy of lowering IOP either by a percentage of baseline or to a specified level. For an example, in the early manifest glaucoma trial, there was a 72% progression of treatment as compared to 45% on therapy when IOP was lowered by 25%. So in this talk, I'll be discussing what is normal IOP, the concept of target IOP, parameters that influence progression and hence the target IOP, suggested methods to determine target IOP, clinical determination and management to achieve target IOP, reassessing target IOP over time, and finally, limitations of using target IOP. So Hollow and Graham found the mean applanation IOP to be 15.9 in males and 16.6 mercury millimeters in females. So 2 standard deviations above the mean was calculated to be 21 mercury millimeters, and hence the commonly held belief that an IOP above 21 should be considered as abnormal and that is below 21 as normal. They themselves noted that IOP above 21 should not be considered as a clinical abnormality as the distribution was skewed. It is therefore to be understood that the so-called cutoff of an IOP of 21 mercury millimeters is not clinical or evidence-based, but a statistical construct. So this should not be taken as an appropriate target IOP or as normal. In addition, there are known racial differences in intraocular pressures. These are some population-based normal IOPs from literature. Setting and achieving a target IOP provide an algorithm for management. Quality of life may be affected by medications used when achieving low target IOPs. But quality of life is also affected by progressive glaucomatous optic neuropathy. It is not only the visual field defects which reduce quality of life in glaucoma, but reduced contrast sensitivity and night vision, impaired mobility and driving also have a significant impact. There are subtle variations in the definitions of target IOPs in different guidelines, but overall concept of target IOP is an IOP that prevents further progression of glaucomatous visual field loss without compromising a patient's quality of life. Quality of life would be significantly affected by progressive visual field loss, and stabilization of the visual field is therefore the major goal. Several parameters influence progression and hence the target IOP. Stage of glaucoma, baseline intraocular pressure, and perimetry are the main parameters. At least 3 IOP measurements taken at different times of the day, ideally with an applanation tonometer, help determine baseline IOP. Reliable perimetry with reproducible visual field defects on at least 2 consecutive fields allows staging of the functional visual loss. Age of the patient is another important risk factor. All these randomized trials have shown that. Additional risk factors such as a family history of glaucoma, thinner central pachymetry, life expectancy, and etc. should also be considered. The extent of existing glaucomatous damage significantly influences progression at a given IOP and therefore is extremely important in determining target IOP. Staging of glaucomatous damage can be done based on either or both structural optic nerve damage or functional loss on perimetry. Unfortunately, there is no universally accepted staging method. As you know, cup-to-dis ratio is more commonly employed in clinical practice and recommended as a means of staging glaucomatous damage into mild, moderate, and severe. Ocular hypertension treatment study found baseline cup-to-dis ratio to be a predictor of further damage in ocular hypertensives. One needs to remember that the width of the rim and the size of the cup vary with the overall size of the optic disc. This shows different disc sizes with the same amount of rim area and the same amount of nerve fibers. Therefore, size of the disc and extent of thinning of the neuroretinal rim needs to be recorded. Perimetric staging is important in determining the target IOP. EMGT found that a greater mean deviation loss at baseline was a risk factor for greater progression. Seagits reported that a unit increase in their baseline visual field score was associated with a 0.74 unit progression. In advanced glaucoma intervention study, patients with greater baseline damage, as evidenced by perimetric MD values of -11, were more likely to progress rapidly. There are many classifications of perimetric staging, such as Haddock classification, glaucoma severity staging system, and etc. They are based on the extent of damage and proximity to fixation. A simple system simplified from Haddock classification based on MD alone is acceptable. According to this, early glaucomatous loss is when mean deviation is less than 6 decibels, moderate loss is mean deviation 6 to 12 decibels, and advanced glaucomatous loss is MD more than 12 decibels. Having ascertained the degree of visual field damage, baseline intraocular pressure, and risk factors, an IOP that would prevent further damage needs to be set. There needs to be a balance between setting a target IOP and being over-aggressive in IOP lowering to avoid side effects and an economic burden. Therefore, patient preference should also be considered. Various approaches for setting a target IOP are developed, but there is little evidence to support any particular algorithm. An absolute or threshold target is easiest for clinicians and is now most often used. Setting a target IOP by percentage reduction has been used in many randomized controlled trials. Formula-based target IOP settings is more time-consuming, but appears to address risk factors in an individual patient. Threshold or absolute values of target IOP are those that are relatively fixed. These are guesstimates given by the European Glaucoma Society. In general, the initial target for absolute IOP cutoffs could be kept for mild glaucoma as IOP 18 to 20 mercury millimeters, for moderate glaucoma between 15 to 17 mercury millimeters, and for severe glaucoma equal to or below 12 mercury millimeters. The large RCTs aim for either percentage reduction in IOP or absolute values of IOP. The odds found that an IOP reduction of 20% leads to progression in 19% of high-risk eyes, suggesting that a greater reduction was necessary. Collaborative normal tension glaucoma study aimed to lower IOP by 30% and found a 5-year progression in 12% of treated patients as against 35% of untreated eyes. So this is a diagrammatic evaluation of target IOP by percentage reduction. The percentage intraocular pressure reduction targeted, that is 20%, 30%, or 40%, depends mainly on visual field damage at diagnosis and on rate of progression. For an example, if the untreated IOP is 20, if the visual field damage at diagnosis is severe, IOP should be reduced by 40%. Formula to set up target IOP incorporate baseline and risk factors in determining target IOP. Jampel first calculated target IOP by taking into account several attributes of the patient, such as initial pre-treatment IOP, Z-score, which is an indicator of disease severity, and Y factor, which represents burden of therapy. These equations are available online if anyone needs to access. So these are clinically applicable target IOP ranges in the presence of risk factors. For a patient with early POAG or PACG, an IOP in the mid-teens with a possible upper limit of 17 mercury millimeters should be initially aimed for. In eyes with moderate glaucomatous damage, it appears that lower IOPs with an upper limit of 15 mercury millimeters would be required to stabilize visual fields. Advanced glaucomas need preferably a mean of 12 mercury millimeters with minimal fluctuations. For normal tension glaucoma, a fall of IOP of 30% from baseline has been shown to significantly reduce progression. So it is recommended to initiate treatment with monotherapy. If it is well tolerated and if the target IOP is achieved, can follow up the patient with regular visual fields. If the target is not achieved, adding a second drug or SLT can be considered. If it is effective, follow up the patient. If the second drug is not effective, can consider third medication or can switch the drug to a different class. If that fails, can consider laser or incisional surgery. If the first-line monotherapy is not tolerated or not effective, can switch or can consider laser trabeculoplasty. This shows the comparative effectiveness of the glaucoma medication. The highest reduction of IOP is with prostaglandin analogs, followed by non-selective beta blockers, alpha-adrenergic agonists, selective beta blockers, and lastly, topical carbonic anhydrase inhibitors. First-line medication is different to first choice of medication. When selecting the medication, not only the properties of the drug, patient's related factors also should be considered. Determination of target IOP is important in management of glaucoma, but achieving the set target IOP does not give complete assurance that disease progression will be prevented. Therefore, re-evaluating the target IOP is necessary. If the visual field is worsening at a rate that may threaten the quality of life during the patient's expected lifetime, then the target IOP should be lowered further and treatment needs to be changed. If there are sufficient visual fields to judge the rate of progression, and this rate is sufficiently slow not to impact the patient's quality of life, then the target IOP may be revised. There are limitations of setting target IOP. IOP recording, even by applanation, is imprecise with known diurnal and physiological variations. Intraocular pressure varies considerably during 24-hour cycle. Consequently, a single IOP measurement during so-called office hours is insufficient to obtain the real IOP. The diurnal variations for normal eyes is between 3 and 6 mercury millimeters, and the variation may increase in glaucomatous eyes. Corneal thickness and hysteresis changes can influence IOP measurements, so that a baseline IOP and the later IOPs should be evaluated, keeping these misjudgments in mind. Aiming for low IOPs in all glaucoma patients need aggressive IOP reduction and may lead to a reduction in quality of life due to the side effects of medications or surgery. So in a summary, target IOP is seen as a guesstimate that will stabilize glaucoma based on severity of glaucomatous damage and other known risk factors. Current studies appear to favor a simple threshold range approach target IOP based on structural and functional changes due to optic nerve damage. In addition, cost-benefit analysis of the therapy required to achieve that target IOP should also be discussed with the patient. These are my references. And finally, I would like to invite you to Sri Lanka next year as we are hosting the Asian Angle Closure Glaucoma Club meeting on the 19th of September, 2025. Thank you.
Thank you, Dr. Dilruwan Ariyasinghe. And I'm pleased to introduce our next speaker, Dr. Andrew Tatham, who will share his presentation on lesson from the UKGTS. Dr. Andrew Tatham is a consultant glaucoma surgeon at Princess Alexandra Eye Pavilion, Edinburgh, and president-elect of the UK and Air Glaucoma Society. He is the NHS Research Scotland National Lead for Ophthalmology, honorary reader at University of Edinburgh, and visiting professor at University of Lausanne, Switzerland. He completed glaucoma fellowship training at Moorfield Eye Hospital and Shilley Eye Institute, University of California, San Diego. Andrew co-chairs and European Glaucoma Society Education Committee and is a past recipient of the ARVO Innovative Research Award, Pfizer Ophthalmic Fellowship, Royal College of Ophthalmologists, Falls Trophy, and 10th Scotland Lady Illingworth Award. In 2023, he was awarded a master's degree in medical statistics. In his spare time, he is a qualified classifier for the British Paralympic Association. Dr. Tatham, the floor is yours.
Hello, well thank you very much for the opportunity to speak about lessons from the UK Glaucoma Treatment Study, the UKGTS. Here are my disclosures. There are many IOP lowering medications available, but I think the standout year was 1996 when prostaglandin analogues, and in particular Latanoprost, became available. And prostaglandin analogues remain our most effective medical therapy for glaucoma. All of these treatments rely on lowering intraocular pressure, and they do that either by decreasing aqueous production or increasing uveoscleral or trabecular outflow. And of course, the prostaglandin analogues primarily increase uveoscleral outflow. But we should remember that intraocular pressure is a surrogate. It's conceivable that a medication might lower intraocular pressure but have a harmful effect on retinal ganglion survival. Or a harmful effect on what matters most to patients, on their visual field or on their quality of life. A good example of this is the low pressure glaucoma treatment study, where patients were randomized to timolol or brimonidine. Although both lowered intraocular pressure similarly, those taking timolol or more likely to progress. So it's important that we choose the right endpoints, patient-relevant endpoints. The Cochrane Group highlighted in this systematic review that the evidence that IOP-lowering medications can preserve visual field is there, but there was a lack of direct evidence for our first-line medical therapy for prostaglandin analogues, and it highlighted that there were no comparisons to placebo. Prior to the UKGTS, the best evidence that we had for a beneficial effect of IOP lowering in open-angle glaucoma with established field loss came from the early manifest glaucoma trial. In this study, patients with early glaucoma were randomized to ALT plus a topical beta blocker versus no initial treatment. Now, of course, that type of initial therapy, ALT and topical beta blocker, is not really modern practice. And in this study, though, IOP lowering, a 25% decrease in IOP reduced the relative risk of progression by 50%. So it showed the benefit, but the UKGTS is the first randomized placebo-controlled trial assessing visual field preservation in glaucoma, and it's the first to look at the effect of prostaglandin analogues. The primary objective of the UKGTS was to establish the visual field preserving effect of a prostaglandin analogue, Latanoprost, on glaucoma. Secondary objectives included evaluating the velocity of deterioration as a trial outcome and to determine whether shorter trials might be possible by modifying visual field frequency or interval and looking at quantitative imaging. It also aimed to look at risk factors for progression and to determine whether initial observation might be feasible for some people rather than immediate treatment. The methods. These were published back in 2013. 560 newly diagnosed people with open-angle glaucoma were randomized to latanoprost or placebo, and they were followed up for 2 years. Exclusion criteria included having moderately advanced visual field loss, an intraocular pressure of more than 35 millimeters of mercury on 2 occasions, and inability to perform reliable visual field testing, and also the presence of significant cataract. The primary outcome was the time to confirmed visual field deterioration. There was also a safety endpoint of a pressure of 35 or more on 2 successive occasions, or a significant decrease in visual acuity. The other secondary outcomes included velocity of visual field loss, the rate of nerve fiber layer change, and change in IOP from baseline. And there are some sub-study outcomes too, which were looking at risk factors for glaucoma deterioration and the association of visual function with measures of quality of life. The testing strategy, well, all subjects had 24 to CETA standard visual fields, and the fields were clustered at the beginning and the end of the 2-year period. Clustering in this way increased the precision of the estimate of rate of change. Patients had intraocular pressure measured using 3 devices, Goldman, Pascal, and the ocular response analyzer. There were also 2 visits where they had diurnal IOP measurements taken every 2 hours. They had imaging using several different technologies. Time domain OCT was the OCT technology used because of starting the study back in 2013. Patients had cardiovascular history taken, they had some blood tests, they had quality of life questionnaires, some specific to glaucoma. They also had questionnaires on driving and falls. So the results of the study were published in The Lancet back in 2015, so almost 10 years ago now. And this really was the culmination of work led by Professor Ted Garway-Heath at the University College London. The baseline characteristics of patients, about 1/3 had a first-degree family history of glaucoma. They were well balanced between male and females, and as one would expect in the glaucomatous population, the majority were in their 50s, 60s and 70s. In terms of ocular baseline characteristics, the mean pressure was actually quite low, so even in the worst side, the mean pressure was 20 millimeters of mercury. There was a quite small number of people with pseudoexfoliation, which really means you can't draw any conclusions about pseudoexfoliation from this particular study. So the main result there was longer visual field preservation with Latanoprost. So at 2 years, 15.2% of patients had progressed when treated with Latanoprost compared to 25.6% with placebo. So that was a hazard ratio of 0.44. There was a greater reduction in intraocular pressure with Latanoprost too. So the mean pressure fell from close to 20 down to around about 15 to 15.5 over 2 years in the Latanoprost group. There was also a reduction in IOP with the placebo group, which is due to regression to the mean. In terms of adverse events, well, we know that topical prostaglandin analogues have a good safety profile, and most adverse events are related to the ocular surface, and of the moderate events, most were related to conjunctivitis or transient visual alteration. There were some more serious adverse events, but they weren't thought to be, most weren't thought to be attributable to the study drug. So some strengths of the UKGTS, well, it involved newly diagnosed, previously untreated participants. So the results weren't affected by prior therapy. It also, due to the placebo group, allowed an evaluation of the natural history of glaucoma. The study showed that it's possible to have a short duration glaucoma study, which could speed up future drug development and reduce the costs of clinical trials. And this short observation period resulted from using sensitive criteria for detecting visual field decline with frequent tests and a large sample size. There are some limitations though, because the study population were predominantly white. It excluded cases of advanced glaucoma, and some things were self-reported, like family history of glaucoma and the presence of systemic disease. So what else have we learned beyond those headline results? Well, the UKGTS looked at risk factors for visual field deterioration, and it found that risk factors included having glaucoma in both eyes, having higher baseline intraocular pressure, and having a disc hemorrhage noted at the first visit. Visual field deterioration rates were similar between older and younger groups when using a cutoff of 68 years of age. Treatment had a greater impact on delaying visual field deterioration in those with a higher baseline pressure, so a baseline pressure of 21 millimeters of mercury or more, shown on the right. The impact of treatment on the time to visual field deterioration was more noticeable in those who had ever smoked, compared on the left, compared to those that had never smoked on the right. Other important findings included that IOP measurements from the ocular response analyzer, so measurements that compensate for corneal hysteresis, were better predictors of progression than Goldmann tonometry, suggesting that Goldmann tonometry is not the gold standard we once thought. Also related to corneal biomechanics, it was found that Latanoprost was associated with a greater difference between Goldmann and dynamic contour IOP compared to placebo, which suggests that Latanoprost induces a corneal biomechanical change, perhaps due to its action on matrix metalloproteinases. So some of the IOP lowering effect of Latanoprost may be due to it changing the cornea properties rather than IOP directly. The study also looked at whether patient-reported outcomes might be sensitive enough to be used as endpoints in clinical trials. The average change in the PROMs was similar, though, between the placebo and Latanoprost treated groups. There was, though, significant differences in the glaucoma-specific questionnaires between those that showed progression and those that did not. But the conclusion was that PROMs may not be sensitive enough as a primary endpoint, especially in early glaucoma. There are two other quick questions that the UKGTS has addressed. Firstly, does the visual field improve after IOP lowering therapy? Well, in this group of patients of early glaucoma, there was no difference between the placebo and Latanoprost treated groups. About 20 to 25% actually had some improvement in their visual field. There was no association between MD improvement and IOP lowering. And lastly, the UKGTS has looked at whether IOP fluctuation might be a risk factor for glaucoma progression, which remains quite controversial. Long-term fluctuation, diurnal fluctuation were not, but ocular pulse amplitude was. So it may be that IOP fluctuations related to the cardiac cycle may be a risk factor. So to conclude, the UKGTS has provided strong evidence to support the vision-preserving effect of prostaglandin analogues, particularly Latanoprost, reducing the risk of visual field deterioration by 50%. It showed risk factors for deterioration include bilateral disease, higher pressure at baseline, and the presence of optic disc hemorrhages. And it's shown it is possible to have shorter duration clinical trials using visual fields as a primary endpoint. So I hope you found that of interest. Thank you very much for listening, and I think we might have some opportunity for questions.
Thank you, Dr. Tata, for our final presentation on the secondary outcomes from the UKGTS, RNFL preservation, and quality of life assessment. I am privileged to introduce Dr. Chen-Chia Su. Dr. Su is the glaucoma specialist at National Taiwan University Hospital and a clinical assistant professor at College of Medicine, National Taiwan University. She received PhD and master's degree from the Graduate Institute of Clinical Medicine at National Taiwan University. Additionally, she was served as a visiting scholar and postdoctoral researcher in the Glaucoma Division of Ophthalmology Department at UK University. She has worked as a clinical researcher in low vision at Kellogg Eye Center, University of Michigan. Her research interests focus on pathogenesis and treatment of glaucoma and visual function in glaucoma patients. Please take over, Dr. Su.
Hi everyone, it's my pleasure to have this presentation. I am Chen-Chia Su from National Taiwan University Hospital. First, I would like to thank Asia Pacific Glaucoma Society for inviting me here. Dr. Andrew has covered the primary outcome of UKGTS, that is the impact of Latanoprost treatment on IOP reduction and the visual field preservation. In this presentation, I will focus on some of the secondary outcomes from the UKGTS, particularly RNFL preservation and the assessment of quality of life. I have no conflict of interest to declare for this presentation. Here, I would like to introduce the design of UKGTS. This was the first multi-center randomized triple-mask placebo-controlled trial to show visual field preservation using an IOP-lowering drug in open-angle glaucoma. The study recruited a total of 516 patients from 10 centers across the UK. The inclusion criteria were patients aged 18 or older with newly diagnosed untreated open-angle glaucoma in at least one eye. Participants were randomly assigned to Latanoprost or placebo. The primary outcome was time to visual field deterioration within 24 months. The secondary outcomes include the preservation of the RNFL as measured by time domain status OCT and patient-reported outcomes related to quality of life, which were assessed at 24 months after treatment. Here we can see the demography and baseline characteristics of the UKGTS participant. Both placebo and the Latanoprost groups have an average age of around 66 years, with similar proportion between men and women. Most participants were white, and about half had both eye eligible for the trial. Other measures like visual acuity, corneal thickness, and eye pressure were similar between the two groups. Latanoprost significantly reduced IOP readings in different IOP metrics, including mean IOP, defined as the average of all IOP readings after randomization, peak IOP, defined as the highest IOP reading of all IOP readings after randomization, supine IOP, defined as the Perkin applanation tonometry readings measured at the first visit after randomization, mean ocular pulse amplitude from Pascal dynamic contour tonometry. Diurnal IOP fluctuation, defined as the standard deviation of IOP obtained from the diurnal IOP phasing performed at the first visit after randomization, and long-term IOP fluctuation, defined as the standard deviation of IOP readings after randomization. Primary outcome of UKGTS results show Latanoprost to preserve visual field in addition to IOP reduction. These slides highlight the effect of Latanoprost on visual field preservation. Over 24 months, patients with Latanoprost had a 56% slower rate of visual field deterioration compared to the placebo. You can already notice the treatment difference at 12 months. Several baseline factors have been identified as being associated with a greater risk for visual field deterioration, including bilateral disease, higher baseline IOP, and dyshemorrhage at the initial visit. Additionally, Latanoprost treatment was protective, with a hazard ratio of 0.42 compared to placebo. The slide outlines the schedule of investigations in the UKGTS. Key assessment including visual field, visual acuity, IOP measurement, quality of light questionnaires, and OCT scans, conducted at multiple sites over 24-month study period. Here we can see the visit for OCT scans. The OCT image was obtained with time domain stratus OCT using a fast RNFL 3.4 scan protocol. For each scan, the average of 3 images taken in a rapid recession was used, as long as the signal strength was 7 or higher. However, in original UKGTS analysis, 10,000, about 21.3% OCT scans were excluded due to low quality. The first RNFL thinning rate obtained from time domain OCT failed to show difference between groups. The figure shows the distribution of changes in visual field mean sensitivity for participants with eligible OCT and visual field data in the Latanoprost group and the placebo group. Here we can see the distribution of rate of time domain OCT RNFL change among the two groups. The mean difference in RNFL change was 0.24 micron per year with p-value 0.08, indicating that the time domain OCT may have been insufficiently precise to detect significant difference in RNFL thinning between the two groups. Nonetheless, from the original time domain dataset, the rate of RNFL thinning on time domain OCT is a significant predictor of visual field progression in the UKGTS. The table displays various covariates for visual field loss, with OCT RNFL slope demonstrate a significant association for time to visual field progression. Dyshemorrhage also appears as a significant factor, with hazard ratio 1.779, highlighting its role in predicting visual field loss alongside RNFL thinning. A generative adversarial network, GAN, is a deep learning model with two neural networks, a generator and a discriminator. A generator creates data like images from random noise, while the discriminator tries to distinguish from real and generated data. They improve by competing against each other, resulting in generation of high realistic outputs. With GAN, the time domain OCT image can be converted to synthesized spectral domain OCT. Here we can see the difference from the time domain OCT and the synthesized spectral domain OCT. So the study group tried to solve the poor measurement precision issue from the original time domain OCT dataset. They used another dataset called RAPID, which contained paired time domain OCT and spectral domain OCT images. As you can appreciate, the Bland-Altman plots show improved agreement between synthesized spectral domain OCT with respect to ground truth spectral domain OCT compared to the original time domain OCT images. With OCT signal enhancement, synthesized spectral domain OCT effectively capture the treatment effect of IOP lowering by Latanoprost, which is showing a significant difference in the rate of RNFL thinning between treatment group and the placebo groups. The mean difference in RNFL thinning rate between two groups was 0.43 micron per year, which was significantly different. Additionally, the rate of RNFL loss on synthesized spectral domain OCT for time to incident visual field progression had a hazard ratio of 1.24, indicating its importance in predicting visual field progression. Next, we are going to talk another secondary outcome, the quality of life assessment conducted in the United Kingdom glaucoma treatment study. As scheduled, participants were evaluated with questionnaire administered at the month 0, which was visit 1, and month 24, which was visit 11. The general health patient-reported outcome measures include European Quality of Life in 5 dimensions (EQ5D) and 36-item short form SF36. Glaucoma-specific patient-reported outcome measures include 5-item glaucoma quality of life (GQL15) and 9-item glaucoma activity limitation GAL9. Here we can see the changes in health-related and glaucoma-specific patient-reported outcome measures between the placebo and the treatment groups in the UKGTS. The data shows the average change in scores were similar for both groups across all PROMs, including EQ5D, EQ5D Visual Analog Scale, SF36, GQL15, GAL9. As you can see, the box plot visualizes the distribution of baseline to exit score. Although Latanoprost show less visual field deterioration compared to the placebo, distribution in the baseline and the exit score was strikingly similar between the two groups. Interestingly, glaucoma-specific vision-related quality of life significantly worsened in patients with progressive visual field loss in the UKGTS. The data compares stable and progressed participants with those experiencing visual field progression reported a greater reduction in glaucoma-specific quality of life measures, such as GQL15 and GAL9. The average change in general health-related QL score, such as EQ5D and SF36, was not significantly different between the stable and the progressed groups. Similarly, we can see from the box plot, Those with greater changes in visual field MD scores had a higher significant change in glaucoma-specific quality of life, but not general health-related quality of life. This slide summarizes the secondary outcomes from the UKGTS we have mentioned today. First, baseline risk factors identified for visual field deterioration. Latanoprost had a hazard ratio of 0.42 compared to placebo, indicating a protective effect. Bilateral glaucoma with a hazard ratio 1.59, higher baseline IOP with a hazard ratio 1.07 per millimercury increase, and baseline disc hemorrhage with a hazard ratio 2.08 all increased the visual field deterioration. Next, regarding the rate of RNFL thinning on OCT, using synthesized SD-OCT, Latanoprost significantly reduced the rate of RNFL thinning. The mean difference in RNFL thinning rate between Latanoprost and placebo was 0.43 micron per year. And regarding quality of life assessment, all PRMs were insufficiently sensitive to capture the effect of Latanoprost in newly diagnosed early-stage glaucoma. However, glaucoma-specific PRMs were effective in monitoring quality of life difference between stable and progressed patients. Thank you for your kind attention.
Thank you, Dr. Sue. And we have now the question and answer session. And there are questions from the audience. And once again, I thank all of our speakers to settle time from their busy schedules. And here's a question from Raghuvaram Seladorai. What should be the frequency of visual field testing in glaucoma patients? I think this question is for Dr. Ariasinger.
Yes, so determining the rate of progression in glaucoma needs significant time span and also at least minimum of 2 years and enough field tests. So for newly diagnosed glaucoma patients, they should be tested with standard automated perimetry at least 3 times per year during the first 2 years. And the other proposal is to do cluster test. In this way, the rate of progression can be determined early and rapidly progressing eyes can be identified early. So most often the frequency of visual field testing can be reduced later depending on the rate of progression when the treatment is started. And for patients with ocular hypertension, they do not need frequent visual field testing.
Thank you. There is another question from Sanjeev Ariyasinga. How does central corneal thickness influence IOP measurement in your practice? And there is another one question from Igor Daniel Rice. Are corneal thickness and hysteresis important factors in the determination of the IOP?
Yes, Central corneal thickness influences particularly the Goldman apprenation tonometry readings. So IOP correction algorithms based on CCT are not validated, so therefore best to avoid those. And the normal CCT, there are different methods to measure CCT. So the normal ultrasonic CCT is about 540 plus or minus 30 micrometers. So if the CCT is higher than normal, then the intraocular pressure is falsely high. And if it is low, then the IOP reading from the Goldman apprenation tonometry is falsely low. Particularly, it's important in patients who have had refractive surgery, LASIK treatment, so their corneas are thin. If possible, you need to get the pre-refractive surgery corneal thickness and IOP measurements so that we can, judge the post-LASIK IOP according to that.
Thank you. There is a question from me, Dr. Andrew Tata. With the result of the UKGTS, do you think the Goldman tonometry is still gold standard?
It's a good question. I think the UKGTS gives us some evidence that having an IOP that takes account of the properties of the cornea might be better. So in the UKGTS, they use the ocular response analyzer, which is an air puff tonometer that measures the hysteresis. That is a measure of the biomechanical properties of the cornea. So and they found, as we said, that the IOP compensated for the cornea was a better predictor of progression compared to Goldman. So I think that I personally think having some knowledge about the hysteresis of someone's cornea is useful. In addition to the corneal thickness, it's probably more useful than the corneal thickness. But the machine's expensive and it's a big bulky machine. It might not be practical to use in all settings. So there are some limitations to using an ocular response analyzer too.
Thank you. And do you think it was ethical to observe patients with glaucoma untreated from the UKGTS?
Yeah, that's a good question, isn't it? I think it showed it was because glaucoma is normally a slowly progressing disease. And I think one of the interesting things was just seeing how even without treatment, it was a relatively small proportion that progressed over it was a relatively short time period of 2 years. So I think it was important to have a placebo group. It does give us that gold standard study that demonstrates that prostaglandin analogues compared to placebo help to preserve vision.
Thank you. There is a question from Smaradace Lorenda, and what the treatment would you prefer for young female adults with already advanced and RNFL loss who is also pregnant? I think this is the questions from Dr. Sue.
Oh, so that was a really tough one. So for a pregnant woman, we know we have only one class B medication, that's brimonidine. But if that is very advanced one, depends on its target pressure. If it needs be really low, sometimes we need to consider the laser treatment or consider the surgery. But mitomycin C could not be used in this condition. So yeah, that's a really tough one. So but for me, I would probably only prescribe the brimonidine during this stage. Yeah.
Thank you. So how do we prevent and manage periocular skin changes associated with Latanoprost use? This is from John Wrong.
Yeah. So we can actually educate the patient to avoid the lead exposure when they instill the medication, the eye drop, and after the eye drop has been ensured that it's absorbed, then we might ask them to kind of clean their wash them, but it's not really have a lot of evidence, but you can try to ask them to like wash their face, try to decrease the lead exposure just after the medication has penetrated into the anterior chamber. Yeah. So I will probably educate them to take care in this way.
Thank you. There is another one question from Donald Fernandez. Would the self do better than Latanoprost as an initial therapy? Dr. Dilruani?
So according to the Light UK, for initial treatment, they have proven that selective laser trabecular gives similar efficacy with similar, quality of life, changes. So I really can't tell exactly whether it's better than Latanoprost, but it has similar efficacy. So if the glaucoma, if I'm initiating treatment, we probably can give the options to the patient. So, and then take, the treatment from there.
Thank you. So there's, I have one question from Dr. Dilruani Ariasinga. And whether low IOPs should be aimed for as soon as therapy is instituted, or whether a graded lowering of IOP should be done.
Whether the initially sudden lowering of target IOP to get low IOPs and compared to progressive IOP lowering. Yes, actually, studies have shown, particularly there's a study done in 2012 by Van Gieser. So they have shown that gradual lowering, they have compared the gradual lowering to, achieving low target IOPs very rapidly. And they have shown that the quality adjusted life years are better with the low target IOPs initially rather than gradual lowering. But we need to be careful when we are trying to achieve very low target IOPs initially, because all these medications, laser or surgery, all these have side effects. So we have to actually weigh the benefits of achieving low target IOPs with the side effects of medication. So, but the studies have shown achieving very low target IOPs initially, particularly with advanced glaucoma, are beneficial than gradual lowering of IOP.
Thank you. There is another one question from May Tan to Dr. Andrew. What is the effect of Latanoprost on corneal hysteresis?
Yeah, this is an interesting one actually, because it wasn't something I was really aware of until the UKGTS. But so Latanoprost increases corneal hysteresis, so it makes the cornea sort of more flexible in a way, and that might that can give an apparent reduction in pressure as well, because if you have lower hysteresis, then there's a relationship between that and lower pressure too. So some of the IOP lowering effect that we see with Latanoprost might be due to that increase in corneal hysteresis.
Thank you. I once again thank Dr. Dilruani Ariasinga and Dr. Andrew Tatam and Dr. Chinchia Su for their time today. Also, I thank everyone who tuned in today. As mentioned earlier, you will receive a short survey to provide your feedback on this event. Only after completion, you will receive a certificate of attendance. Your participation will help us to improve on future professional development offering. Before we end, we again thank to Beatrice for its support towards APGS educational endeavors. And on behalf of APGS, we would like to invite you to attend the 2026 Asia Pacific Glaucoma Congress that will take place in Singapore on 24 to 26 July 2026. APGS on YouTube, and we encourage you to subscribe and set your notification on so you can be updated on our online content. So concludes today's Asia Pacific Glaucoma Society webinar. Have a wonderful day or evening, depending on where you are. You may now disconnect. Thank you.
Thank you.
Thanks very much. Good
Thank
to see you.
you.
Thank you.
Thank you.